Thank you all for coming out today, taking your Saturday. I know you could be home, doing other stuff, spending time with your family, or just relaxing. But, we have some fun stuff today. We're going to do some interesting things, and I've been tasked with making science exciting on a Saturday morning. So I think I can probably do that. I'm not sure if I can make it super sexy, but I think I can make it somewhat interesting at least. Right now, all the buzz that we hear, and we've been hearing for several years, and I know several of you in the room have been in regenerative for a long time, but the buzz that's out there right now, you'd think that this just landed on Mother Earth like a couple of years ago because it's this brand new phenomena. Reality, stem cells were discovered in the 50s, right, by Friedenstein and his colleagues, and they noticed something completely different. Instead of a cell just dividing and becoming another one of its cells, they had noticed that in vivo, these cells had the potential to become adipocytes, chondrocytes, and also osteocytes. So after that, the first successful bone marrow transplant took place in 1968, and by 1978, stem cells were identified in the umbilical cord blood. So we're going quite a ways back. I mean, even I was still in high school then. Well, almost. I was not quite. By the 80s, stem cells were isolated from adipose tissue. UCLA, working together with Penn State University, saw that, and things really started to move quickly. By 1988, the first successful umbilical cord stem cell transplant took place. Blood-borne dyscrasias, which are still the approved ones around the world. So just so everybody's on the same page and we're all talking the same thing, and I know you guys know this, but I still have to do it for sake of completeness. You know, we have autograft, allograft, and xenograft. Autos from ourself, allos from same species. Different human, xeno is from a different species, and you're familiar with xenografts. I mean, in early heart valve transplants, there's a pig valve, right, to be considered a xenograft. Primarily what I will talk about is allograft, primarily cord blood. However, there will be discussion about the other things today. So the International Society for Cellular Therapeutics is kind of the defining guideline on a stem cell. And it gives certain criteria, 3 basic criteria. Number 1, it must be adherent to plastic. Okay, regular cells are not typically adherent to plastic, so it's a lab cultural thing, a culture in the lab where they can actually look and make sure they're adherent to plastic. Number 2, they must express CD105, CD73, and CD90. I'll back up 1 second before we go too far. The International Society for Cellular Therapeutics definition is based on purified mesenchymal stem cells, which means that you would have to remove the purified stem cells, grow them in culture, and then look for these characteristics. We do not use a purified form of mesenchymal stem cell in the United States because that would be considered more than minimal manipulation and fall outside of the FDA guidelines. So I'm giving you this definition so you understand it, and I'll talk about it a minute later. The product that is out there, specifically in the United States, is a heterogeneous mix of cells. Yes, there's some mesenchyme, and there are all those components in there. But just for definition purposes, for a purified product, you have to see 105, which is primarily hematopoietic, CD73, which is for tumor suppression characteristics, and CD90, which is what we more well know as mesenchyme, MSC'S. Also, they look for a lack of expression in some other ones, 45, 34, 14, and on down the list. The reason they're looking for lack of expression is if you're using a purified mesenchyme, you don't want them differentiated. So it has to be a purified mechanism from there. Number 3, they must be able to differentiate into bone, fat, and cartilage. So this was written over probably 20 years ago. And they recognize criteria will have to change, and I think we're going to be seeing that in the very near future. For our purposes, what we're looking for are really 2 main qualities of a cell. Number 1, that the cells are renewable. They undergo mitosis and have the potential to duplicate themselves. And number 2, they have potency. Potency, defined in the stem cell world, is the ability to differentiate. So umbilical cord cells do have the potential to double, or population double, every 24 to 28 hours for really up to 90 generations in vitro. Probably not in vivo. 10 years ago, probably even 5 years ago, we thought that they continued to do it in the body. But it's kind of questionable whether or not it does. Probably 90% of the scientific community says it's such a toxic environment in there because you're putting it into damaged tissue anyway. They may or may not actually population double, but they're certainly not going to do it for 90 generations. Probably the best example is if you were to take umbilical cord blood stem cells and put them in a baby's blood, an infant's blood, and put them in culture, they would rapidly duplicate. But put them in a 30, 40, 50-year-old's blood and put them in culture, and it's questionable what they would do. It's pretty much dependent on the environment. Now, BMAC and adipose also have the potential to duplicate in vitro. However, with age and disease, that's where it tends to slow down. Also, we know that there's greater autoimmune disorder in people over the age of 60, and that does damage the BMAC and adipose tissue stem cells. So MSCs do not necessarily readily duplicate in vivo. However, they do produce long-term effects by responding to signals from injured tissue. Among the primary effects is modulating the inflammatory and immune response to injured tissue. That response is typically excessive and contributes to pathologic change. MSCs secrete inflammatory and immunomodulatory factors, including this litany of alphabet soup, TGS6, PG2, TIMP2, interleukin-1RA, many, many more. And they synthesize various growth factors, cytokines, exosomes, and microRNA. We are in the process right now of doing a proteomic heat map display of at least 40 of the known cytokines and proteins, but it takes a minute to do that. And we know there are hundreds in there, but what we try to do is just go through a sampling of them so that you have a greater knowledge on how you can talk to your patients. So TSG6, it's a short acronym for a long word, tumor necrosis factor alpha stimulated gene protein 6. It modulates and decreases the downstream effects of the pro-inflammatory cytokine tumor necrosis factor alpha. Everybody knows that TNF alpha, one of the most common inflammatory components in damaged tissue. It's also an indicator in many autoimmune disorders. An increase in TNF alpha directly relates with an increase in disability, cognitive dysfunction, and death. Number 2, PGE2. This is not your classic PGE1. This is not your classic prostaglandin. This is PGE2, which acts to suppress the T cell receptor signaling and plays a role in the resolution of inflammation versus a PGE1. Also, like TSG6, it acts to decrease the downstream effects of the pro-inflammatory cytokines. And that's important to remember so far, the downstream effects. The first two do that. So the net effect is to decrease the amplification of the pro-inflammatory signals through the secretion of interleukin-6, which then inhibits TNF alpha, interleukin-1, and stimulates interleukin-1RA, receptor antagonist, interleukin-1, which stops interleukin-1, and also interleukin-10. And if you're worried, yeah, there will be a small quiz afterwards. I mean, in order to get lunch, but, nothing too big. We also see TIMP2. This is really interesting. The tissue inhibitor of metalloproteinase 2. So in our body, TIMP2 that comes with these cells inhibits the formation of MMP2 and 14. MMP2 and 14 are the matrix of metalloproteinase 2 and 14. What they do is they break down the extracellular matrix, specifically causing the degradation of type 4 collagen. So MMP2 and 14 that we see in injured tissue is breaking down the type 4 collagen in our body. The TIMP2 helps to stop that and suppress that MMP2 and 14. So also type 4 collagen, as you know, is responsible for binding and integrity of the basement membrane, and the basement membrane is basically what binds and holds all our cells together. Also very important in cell signaling. So for number 4, interleukin-1 RA. It's a natural inhibitor of the pro-inflammatory state. It inhibits interleukin-1, which is a pro-inflammatory. It also inhibits tumor necrosis factor alpha. And as we said, TNF-alpha is indicated in many autoimmune diseases. It is also well known that an increase in TNF-alpha has that direct correlation with disability. The point here being, the first 3 I talk about downstream, stopping the downstream formation. Interleukin-1 RA is the only one that works in sight. And the reason I tell you this is because your patients are going to say, Doc, you're going to put this in my joint. How quickly am I going to have pain relief? Well, it can take a minute. It can take a while. Because interleukin-1 RA is principally the only one that's working in sight to suppress the interleukin-1, the pro-inflammatory cytokine interleukin-1, whereas a lot of these other proteins and growth factors are actually stopping the downstream formation of it so we don't see it. So it can take a minute. You got to suppress the inflammatory components in the joint, and typically that can take a while. So when we talk to people, we usually say, if you talk to your patients in the terms of weeks and months, they'll probably be pretty happy. If you talk to them in terms of days, they're not going to be very happy. Like I'm not going to be very happy in a minute. So we went through a bunch of the cytokines and interleukins, and what else do they do? Well, they also have anti-apoptotic properties. You know that apoptosis is considered programmed cell death, literally cell suicide. These umbilical cord blood stem cells do have the ability to rescue apoptotic cells induced either by trauma, exposure to hypoxia, chemicals, acidity, whatever, or even mechanical damage. So anti-apoptosis is actually a very big effect. On the studies that are being done around the world, central nervous system, cardiac, and all that sort of thing, the sooner they can get the cells into the body, the less cells that have been damaged undergo apoptosis and the less scar formation. Dr. Jack Willingham of University of Texas in Houston did a study on anterior wall myocardial infarct. And if they were able to get cells to the site or even circulating within 14 days, they had very good response. But after 14 days, that MI is no longer an inflammatory component and is turning into scar tissue, and they had far less results. So early application with anti-apoptosis has been very successful. They also have some antimicrobial properties. This is not very well known. They think it's a polypeptide LL37, but in other studies around the world, what they definitely have found, it also works very well against protozoa. And I know some guys in this room that know that very well. So with Lyme disease, they've shown a lot of progress in studies elsewhere where they're using it systemically, and they've had some very good results from that. So far we've seen that MSCs duplicate themselves in vitro in the lab, but however much in the body we really don't know. They do secrete anti-inflammatory and immunomodulatory factors, and they synthesize various growth factors, cytokines, exosomes, and microRNA, and we just named a few of them, TSG6, PGE2, and the other two. So what next? So now we have the MSCs in this injured environment, and they're secreting the anti-inflammatory factors that help to inhibit the inflammatory process. The MSCs help to optimize the environment around the damaged cells by inhibiting this inflammation. Now your own body, along with the components in the umbilical cord blood cells, have the opportunity to begin to regenerate the damaged tissue. Now the growth factors, cytokines, exosomes, and microRNAs from the umbilical cord cells can now begin to work with your own body on the damaged tissue. So the growth factor action. There are many growth factors and proteins in umbilical cord blood stem cells. Published proteomic heat maps of more than 40 significantly relevant growth factors in umbilical cord blood. When we saw the proteomic heat map of the 40 recognized ones, that's exactly why we, at the lab that I worked at, we decided to do the same study, because we would like to identify and prove that in that product that they are producing, that it also has those significant 40 growth factors. So there are many, and we're not going to go over 40, certainly, because it would be tiring for me more than you. But let's do some clinically relevant ones, such as VEGF, vascular endothelial growth factor. So it's a protein produced by cells that stimulates angiogenesis. That's awesome. Well, you say, well, who cares about angiogenesis in a joint? Cartilage is avascular. How about the bone underneath the cartilage? Many times the damage to the cartilage is because it's lost its vascularity with the blood supply on the bone underneath. So if it can help to repair the microvasculature in the bone, or in the capsule, or in the ligaments, or the tendons around the area. So VEGF is big. FGF2 is one of the most powerful mitogens in our body. Mitogens stimulate cells to undergo mitosis. That's what we like to see. When you're young, at 10 years old, and you fall down and injure yourself, 12 minutes later, you're completely ready to go, and you're back at it, because our body is doing what we're supposed to do. Fortunately, as we get older and a little more damaged and living in the world, we tend not to have that much stimulation of FGF2. A lot of immune cells, regulatory T cells in the product. A very high percentage of it are actually the regulatory T cells in the body. That helps to balance the immune imbalance that's in the area. If you have a pro-inflammatory condition, then you are going to be out of balance in your immune system. Your T1, T2 helper cells at that site are going to be out of whack. And this helps to balance them. There's also a thing called stem cell factor. This is becoming more well known and, quite frankly, a little more exciting, because we know that we have live stem cells in pretty much every tissue in our body. But as we age, they become inactive. However, when in the presence of even an allogeneic product, now to be fair, in the presence of an autologous product too, the same thing will happen. But it stimulates our own endogenous stem cells to become activated. And what they've shown in animal studies, you can place an injection in a different part of the body, even a joint, and it will stimulate the stem cells in their bone marrow to become activated and migrate to that site. So it is effective, and stem cell factor is very real. Endothelial progenitor cells, very nice. It's a stage directly after a stem cell before they really become something. So in an autologous endothelial progenitor cell in your body, your own, it has the potential to become whatever it needs to be in that state. What we see in an allogeneic product with endothelial progenitor cells is it stimulates the endothelium. And when you stimulate the endothelium, you have release of nitric oxide. Release of nitric oxide, you have vasodilation. So you get the healing process beginning to happen. This is probably one of the big things that they talk about in ED, because they'll do a direct injection for ED into the cavernosum. And the nitric oxide that's released causes those sinusoidal cells to relax immediately. And before your injection is done, sometimes you have a little action on hand. Fibroblasts. Important structural framework and stroma for tissue. People say, well, we're putting in a joint. What are we going to put for a matrix so that it helps to grow it? Fibroblasts are in there, and it does help build that stromal structure. Can other matrices help? Of course. Of course. I mean, you can't be, there's no one size fits all. I mean, we're learning more and more about it. The study that was done in South Korea for chondral defects, they took stem cells, mixed it with HA, and put it in the chondral defect. It was amazing. I mean, they find that patients with a meniscal tear, if at some point in time you'll supplement with HA and the cells, they do better. Doesn't seem to make that big a difference on osteochondral specifically, but we know on a lot of the soft tissue repairs, it really works quite well. So fibroblasts are in there. And then, of course, there's nerve growth factor, stimulates and regulates nerve growth. I don't want to be misleading in any way, shape, or form, because you see it all the time. You know, patient has a spinal cord injury, been in the chair for 29 years, and says, I want to have stem cells because I want to walk again. This would regrow those nerves. No, it doesn't. This does not contain any oligodendrocytes or anything that's going to recreate or create brand new nerve tissue. You know, it can help give nourishment to nerves. We see it in peripheral neuropathy a fair amount. It can help to break down some scar tissue, help those nerves. You're not going to create a new nerve or a new nerve pathway with this product. PDGA, a platelet-derived growth factor, interesting. It stimulates cell growth, but it also regulates it, which is pretty important. You don't need to have a bunch of extra tissue. So like a normal system in our body, once you get what you get, it turns it off. We see this a lot in, well, I mean, there are a lot of conditions, but I think it's most relevant in like gingival disease, where you have a gingival recession and you have a root that's being exposed on their teeth. And dentists will use it. They'll take a small vial, add some saline, and put it in all the quadrants of the mouth. They find that the antibiotic capabilities helps, that they get rid of the bacteria, but the gingiva will grow down to its regular line and stop somewhere in that area. It doesn't go down and cover the complete tooth or anything like that. So it's speculated that maybe it's a platelet-derived growth factor that stimulates it and then stops it. And then, of course, transforming growth factor beta. This is important for, obviously, intra-articular injections because it does stimulate. This is one of the mitogens that does stimulate healthy chondrocytes to duplicate themselves and grow. So let's kind of put it all together in a simplistic term. Damaged cells put off a chemical in the space around them, the paracrine space, right? Umbilical cord blood stem cells, which I'm talking about today, and which all cells really are attracted to this chemical signal. It's primarily TNF-alpha and all those sorts of things. They will then attach themselves nearby blood vessel and become a pericyte. From that site, they will give trophic or nutritional support to the damaged cells, helping damaged cells become healthy. And then the other growth factors, like the fibroblast growth factor 2, will then stimulate healthy cells to begin to duplicate themselves. All this is done through a paracrine signaling mechanism. There's no engraftment of these cells into your body. When you get the great question, well, what about DNA? What if they transfer DNA? The only thing that happens here is paracrine signaling. These are allogeneic cells. They're not autologous. They will live their lifespan, we don't know, several weeks to several months. They will do their function. They will undergo their own senescence and apoptosis and be picked up by the lymphatic system and go out the body. But they do not become part of our body. This is all done through cell signaling or paracrine signaling. So when umbilical cord cells are injected into the body, the MSCs, allogeneic MSCs, primary function in our body is anti-inflammatory and immunomodulatory. It's not like an autologous MSC. An allogeneic MSC does not work the same way. So we get very strong anti-inflammatory and immunomodulatory capabilities from an allogeneic MSC. The live nucleated cells then secrete growth factors that helps to nurture the damaged tissue to become healthy, and then it can stimulate healthy tissue to undergo mitosis and duplicate. The live nucleated cells also secrete stem cell factor. That stimulates our own endogenous stem cells, either in situ in the niche or to become activated elsewhere and migrate to the area. And that's where the true differentiation of new tissue takes place. There have been multiple studies, specifically intra-articular, dealing with injection into joints and following up arthroscopically and through MRI CT. And what they find is that within 3 months when they go in there arthroscopically, very little change. Yet, you're probably going to have the best subjective response you're going to have from your patient at 3 months because it has inhibited the inflammatory components, but very little change has taken place in that joint. When they did arthroscopy at 6, 9, and 12 months, 6 months they started to see change, 9 was more, but they continued to see change 12 months down the road inside that joint. nobody thinks that these cells are still active at 12 months. I mean, I think the biggest I've ever seen is Neil Reardon, and he gives a wide range of 4 to 8 months. Animal studies are in weeks, right? They've seen it as short as weeks in animal studies. So who knows how long the cells are actually there? The point is, it sets up a cascade and starts that cascade, and our body starts doing what it's supposed to do. And they believe that the continuation of it is not only that cascade, but also the recruitment of stem cell factor, that our own autologous stem cells become activated. And it probably makes a little sense why your 80-year-old is probably not going to get as good a benefit as your 50 or 60-year-old, because by that age, we have significantly decreased not only quantity of stem cells in our body by 80, but the ability to differentiate is significantly reduced, even with a healthy 80-year-old. But a lot of them even have an autoimmune disease in process. So we've seen that they contain live nucleated cells, and they contain this alphabet soup and all this other stuff, also proteins, cytokines, exosomes, and microRNA. There's a lot of microRNA. MicroRNA are microvesicles that are in the extracellular fluid. An average stem cell is 5 or 7 or 8 microns in size. An average microvesicle microRNA is about 50 nanometers in size. So while they don't know how much of this actually gets across the blood-brain barrier, the 5 to 7 micron size stem cells, they're pretty certain that the microRNA at 50 nanometers, 1,000 times smaller, has the ability to cross the blood-brain barrier. And that's where exosome therapy is really coming into effect. And Dr. Rafael Gonzalez, a little later on this morning, is going to do a talk on exosomes. He has extensive experience with exosomal therapy. And a couple years ago, we thought this was going to be the stuff, exosomes. It's good. It's very good, but they don't have any live nucleated cells, so we don't get that long progression of it. They undergo their half-life, and it's relatively short. So why are live nucleated cells important? Well, live nucleated cells will continue to create growth factors and related proteins for weeks and possibly months. We don't know exactly how long, but we do know from arthroscopic and MRI evaluation that the joint continues to change even at 12 months out. The longest known study was a 7-year follow-up study, and they still had significant results at 7 years. There was one autologous study of 395 patients scheduled for a total joint replacement. And after they gave them stem cells, 1 year later, only 12% actually had the surgery. Radiographically, the joint was better, but not like, oh my God, look at this, it's amazing. It's just that the patients didn't have pain, subjectively have pain. So they believe that the live nucleated cells give us that potential. So what products consistently have that? Obviously, umbilical cord blood cells, bone marrow aspirate, and also adipose derived. Also, I think it's really important, if you're going to be in this industry, that you look at the product itself. Because, I don't know, you see every day there's another one that pops up on another corner. A lab is over here, somebody's doing this. It's a new name in the industry. They're selling this and they're selling that. And the salespeople will tell you whatever they want. The bottom line is third-party verification is going to be the most important thing to have. Third-party verification, not testing. You're going to do testing in your own lab, of course, because you need to know what your product is, what your characteristic of cells are, and everything you have. But you need to have the ability to validate that with an unbiased third-party source. So my recommendation would be, if you're going to be in this industry, that you definitely get a third-party verification. Make sure that the company you're going to use has third-party verification of what they're doing. Go visit their lab too. I mean, go see what kind of facilities do they have. And when you're at that facility, visit their compliance department. Compliance is the key. Compliance makes you live or die. It's not really difficult to get a CGMP lab. CGMP stands for Current Good Manufacturing Practice. People think that the C stands for certified. No, the joke is that in the FDA, the regulations are changing so often, the best you can hope for is to be current and never certified. So there's CGMP and there's CGTP, good tissue practice, handling practice. So you can get CGMP, CGTP certified. If you get a few $100,000 and you have a location, an outside firm will come in and build it, and that day, you are CGMP, CGTP certified. If you don't follow protocols starting the very next day, you are no longer CGMP or CGTP certified. It requires unbelievable amounts of, well, first of all, paperwork to make standard operating procedures so that every single thing that goes on has to be documented. Our lab, it costs between $12,000 and $15,000 a month to maintain CGMP, CGTP status. And that's by having regular dynamic testing of the clean rooms. ISO 7 clean room with an ISO 5 biosafety cabinet. So during the day when people are working in that lab, one person, the quality analysis person, goes in and puts out cultured plates throughout the lab. Also cultures the people working in the lab, because you're fully covered, you're doing the whole gowning process head to toe. If you have a beard, you're wearing a, that sort of thing. And they have to test that every day for dynamic testing. And then once a week, they put out plates overnight for static testing to see what it looks like in that lab. If it ever falls out of compliance, if there's ever more particulate allowed by ISO 7 or in the biosafety cabinet ISO 5, which is tighter, then that triggers the standard operating procedures where it must take place, that a whole procedure has to go along. Also, once a week into each one of those areas, a specialized outside company that specializes in clean lab, in CGMP labs, comes in and they clean every hard surface in the lab. Every other week, they scrub the walls and the ceiling. So, I mean, this goes on constantly, and the compliance is probably more important than anything else. If you have compliance, you have a good idea that you're safe. So MSC verification from a third-party independent lab is also incredibly important because you don't know exactly what you're getting. Viability of a live cell count. Lord, if you guys even have an internet connection at your house, you've heard about this one. Live cells. Are there live cells? One of our buddies in the BMAC world says there are no live cells. So I asked Dr. Gonzalez, I said, and what would you say to that? He said, well, there are hundreds of peer-reviewed studies on umbilical cord blood cells that show live MSCs. Number two, if there's no live cells in cord blood, then cord blood storage is the biggest scam in medical history. And number three, if there are no live cells, then how come at the Duke study, where they treated intravenously from umbilical cord blood cells the treatment of cerebral palsy and autism, did they get good results and they had validation and verification of live cells? So there are definitely live cells in the product, but it's important to know your viability in your live cell count. At the lab that we built, when the cord blood comes in, number one, FDA, and a lot of people don't know this, and we'll talk about this later today on guidelines. There's not a lot of guidelines to follow. And the ones you had to follow, make a distinction between guidelines and rules. They're guidelines. If you've ever read the Title 21 Code of Federal Regulations 1271.1, paragraph 361, it says right on there, these are guidelines that we may or may not choose to enforce. So you are responsible for making sure that you follow CGMP status, CGTP status, then you're going to be within guidelines that are acceptable. So in our lab, we are required to get our cord blood in less than 48 hours. The average is about 26. It's pretty hard because we get them from different places around the United States to get them in 12. That would be nice, but we don't have that capability. Average is about 26. The second it comes in, it is tested for viability and is placed through a Sysmax machine, which is a hematology analyzer. Basically, they do a CBC with the diff count, because if there's a left shift of white blood cells, you only have really two major things that are probably going to be, right? An infection or an inflammation. Well, you got to assume infection. So we've seen it once. We saw it once about a week and a half ago. There was 3 times the immature white blood cell count. And they don't even question it, they throw it away. So the first thing that comes in, they test for viability and they do a CBC with the diff count. Viability is typically right about 90%. So within 24 to 26 hours, we've already lost 10% of the cells. Midway through the process, after the whole red blood cells have been removed, after the HLA-DR has been removed, before the DMSO has been put into it, it's tested again for cell viability. Then it is typically around 86 to 87%. They typically lose about 2% during that process. They then add the DMSO and cryopreserve it. When you add DMSO, it makes the cell membrane permeable. So as they freeze it, the cells don't explode when they go through the vitrification process, right? When they crystallize. They take it down 1 degree per minute from room temperature to -80. It takes a minute to do. After it has been cryopreserved, they will then test it a third time by thawing it and finding out what post-thaw viability is. It's very easy to write on papers, we have 90% viability when it comes in the door, because you should. Matter of fact, if you could get it in less than 24 hours, you get it in 12 hours, you probably have 95% viability. But if you're going to be honest about it, it's got to be post-thaw viability, because you can't use those cells. You cannot use a cell that is not at least 14 days old, because that's how long it takes to do the USP71 sterility testing for endotoxins. So to say that my cell has 90% viability, it's true, but it's disingenuous, because you could not use that cell. It's not been tested yet. It has to go under cryopreservation and has to be in quarantine for a minimum of 14 days until you get the USP71 testing back. So viability is cool. Third-party USP71 testing is important. It's not required, which I don't understand this. November 2020, a lot of things are going to change. It's currently not required to have third-party verification on USP71. USP71 is for sterility. They also only require USP71 testing to do a 3 to 5 day Petri dish analysis in your lab. I mean, I don't remember much about microbiology, but I do know that it takes endotoxins longer time than that to show up. And you won't always see a gram negative in 3 to 5 days. So the right way to do it is to send it out to a third-party CLIA certified lab that the only thing they do is USP71 testing. And then we set it up for the 14-day endotoxin test. And so safety is really the key to all of this stuff. So do non-nucleated cells have value? Sure, we're talking about PRP, we're talking about amniotic fluid, we're even talking about exosomes. Absolutely. You know, even autologous PRP, you're going to get your autologous growth factors, you're going to get some anti-inflammatory components, and people get a boost. You probably all put PRP in a joint. Patients are like, I'm great. Problem is, a month later, they're like, damn, that thing doesn't work anymore. Well, no, it did what it was supposed to do, right? So non-nucleated cells definitely have value. There's absolutely no doubt about it. And there's a time and a place when it's actually better to use them. We're seeing Dr. Jack Andrews is using some exosomes for ulnar collateral ligaments for baseball players so that they don't have Tommy John. And it's working very well, because you're not looking for this massive regrowth of tissue. You're looking for an anti-inflammatory component in a young, healthy individual so that their body can do what it's supposed to do. So if they don't have a nucleated cell, PRP, amniotic, exosomes, that sort of thing, they just don't last as long. Without the nucleus keeping that cell alive, you just get the growth factors and cytokines that are on the cell wall or in the area. And it can last for, several hours to several days.